Good afternoon, everyone. Thank you for staying to continue our session. So without any delay, we will welcome again Dr. Sumer Dasdi to talk to us about navigating the challenges, innovations in pediatric hand surgery.
Thank you again. We're going to talk about pediatric hand trauma, slightly different. So this talk is not about developing this magic regeneration potential in children. It's not about robotics in hand surgery in kids, because that doesn't exist. And as far as I know, K-wire technology hasn't changed in the last 60 or 70 years. But I'll highlight a few challenges in pediatric trauma and try to discuss some of the innovations that have gone around it. The first thing to recognize is pediatric trauma is a public health problem because it is so common, especially in the upper extremity. It also has a domino effect on parents and caregivers, because once the child is injured, parents and caregivers have to take time out for them as well. And because the child lives for another 60, 70 years, the impact on quality of life is significant. This is interesting studies done in Sweden which have shown that over time, things have changed. Kids tend to get injured earlier now, probably because they're more aggressive with sports, maybe because of the obesity problem. But the overall trend in trauma is also going down over the decades, and that is because of better social engineering, like toy manufacture, architecture of your playground, home environment. So things like these are probably more important when it comes to preventing or reducing pediatric trauma. That's a picture of my son, and he wants to play cricket for the IPL someday. The second challenge in pediatric upper extremity trauma is misdiagnosis is very common. This was a study done by my colleague in Singapore detailing the reasons for this. The main reason for this is because children are difficult to examine. It's difficult to take a history, difficult to examine them well. There are also very unique ossification patterns in the hand, which make it difficult to identify fractures. There could be a very small sliver of bone in a Salter-Harris fracture. It could be an accessory physis which is mistaken for a fracture. It could be a bone like the scaphoid that's not even ossified yet, which is injured. So there is innovations where the role of AI in detecting pediatric hand fractures. This was a recent study which showed that the AI algorithm could pick up the fractures better than someone who's not so experienced, like a pediatric resident or orthopedic resident. The second challenge in pediatric hand trauma is that there is inadequate data for decision making. We know certain things for a fact. Children heal faster than adults. We know that they have great remodeling capacity, and some of these parameters have been studied very well in the distal radius, for example. But we don't really know much about certain areas at all, such as remodeling in fingers, whether rotational deformities remodel. I conducted a systematic review recently, and we found there's very large gaps in knowledge in this area. This can lead to missed opportunities. For example, we have this girl who is 12 years old. She's reaching skeletal maturity. She's tall. She's a bit heavy. And at 1 week, everything is well reduced. At 2 weeks later, everything is displaced. And at this time, it is very difficult to do anything closed, which means you have to open up. And you also need to put an implant that has a bigger footprint, such as a physeal sparing distal radius. So if you can predict this instability pattern, you can do something about it instead of doing this big procedure. So there is a need for big data in pediatric hand surgery. This is why we have large data sets and collaborative registries. And probably AI will play a big role in these algorithms. This is a picture of the first Asia-Pacific congenital hand group that we formed, and you see some familiar faces here as well. The fourth challenge is that iatrogenic problems are more common than we think. Because children's bones are more fragile, they are smaller, the blood supply can be tenuous. There is a high risk for things like avascular necrosis of the bone, partial physeal arrest. So techniques that can reduce these complications are very important. They may not be very cool innovations, but they are worth sharing, such as hand drilling of bone with a needle to reduce thermal injury, percutaneous fracture reduction. This is from my colleague Alphonsus Chong's work. This is a percutaneous joint reduction without opening up much. And this is a case which I encountered recently where the child had lost the entire proximal phalanx because of infection. And I did a bone grafting, but preserving the physis. So it's a physeal sparing sort of chondrodesis at both levels. And hopefully that will give him some growth. The fifth challenge we have is children have very different demands. If we get injured, we go back to the office, maybe we do a bit of less work. But for children, it's either 0 or 1. Either you're at home sleeping or you're smashing a ball, at this great sort of, in terms of demand. So simple things like waterproof casts have improved functional recovery in children. Our own group in Singapore showed that splinting for most fractures is, even for very exacting fractures like phalangeal neck fractures, is just as good as casting. So that's what we routinely do. Some of the simple things we can do with surgery and post-operative care, such as absorbable sutures and very specialized dressing and care plan, makes things a lot easier for them. And things like, we did a study with some colleagues which showed that leaving the pins outside when you pin a lateral condyle fracture is also more cost effective and comfortable for the child. So these are small things that make a difference. The other thing I think we should do better is to measure outcomes that make a difference, right? There's a big move towards patient-reported outcomes, and this is, for example, the ICHOM database that they use for congenital upper limb anomalies, and we can adopt a lot of these things to measure both functional outcomes as well as social outcomes, which is basically aesthetics. The sixth challenge is that the bad stuff in kids is uncommon, but they do happen. Once in a while, you get things like this happening. And there are no such things as pediatric vascular surgeons. If you have a bad pediatric injury in the lower limb, it's the microsurgeons that have to go in. So we need to organize services very differently for children. This includes intensivists, social services, even mental health specialists. And in Singapore right now, we have this inaugural Center for Trauma where pediatric trauma is a national priority, as it should be. The last challenge I want to highlight is that pediatric hand surgeons are scarce in the areas where you need them the most. In other words, where trauma is neglected, you have the least number of well-trained people who can manage complicated problems like this. And among all the outreach programs in the world, I think the one that I like the most is the one by Be First. They call this the Global Reconstructive Strategy Program, which is not based on going to a country and doing surgery, but is based on developing a training curriculum to educate and build services in a country. And I think this is what is needed to optimize pediatric hand trauma care in these settings. So those are my 7 key challenges, and I think I'm right on time. Thank you.
Thank you, Showman, for a crisp and comprehensive idea about the challenges we face with pediatric hand trauma. If there are any questions for Dr. Dasde from the floor. I guess not. Thank you, Showman.
Thank you. Thank you.
May I ask my co-chair, Dr. Christina, to start her talk?
Good afternoon again, everyone. First of all, thank you, significant thank you for the organizing committee to having us here, all the team from UAE. And I guess I got a very good introduction from my previous colleague speaker. I will give you my idea of how I deal with the pediatric patients in the clinic and maybe some tips and tricks. I'm going to also refer to some products. There's no correlation, no financial benefit from my side, but if you have them, you might find it good to use them. So first of all, when a kid comes to the clinic, especially after an injury, you have to deal with the patient, but also the parents. So at the same time, you have to have a nice environment for the kid to examine, but to reassure the parents that you actually know what you're doing. I have lots of toys and stuff in my office. Since COVID, this has been a little bit minimized due to infection protocols. But soap bubbles, it's something that I find useful to use, little toys for the kids. And always start the clinic evaluation with a very nice and open question: how may I help you? Even though I know what the kid might have, even if I've seen the x-ray or I got a referral, and I know that it's a severe injury or a very benign condition, I want the parents to just be with me in the treatment. They might tell me things that I cannot see, and also to reduce their anxiety, right? Even a small injury can be stressful for them. And when we finish the consultation, always ask them, do you have any questions? Is there anything that you need to know more or that we haven't covered? Have in mind that even a very benign condition, as an extra-articular radius fracture, that we all know it's going to heal easily, nicely with some simple immobilization, it's still stressful for the family if it's their firstborn. In Dubai, especially if it's a girl or a boy, what's going to happen? Is the growth going to be affected or not? You have to take your time to discuss with them. The same way that you're going to discuss a Kienbock disease, that it's a more serious condition. And as most of you might encounter on everyday practice, people come knowing exactly what their kid has. They've searched Google, they know the diagnosis, they know what's the treatment, and they tell you, okay, this is what you have to do. It's always nice to draw the fracture pattern, also discuss with them what is the fracture that you're seeing. For Salter-Harris classification, it's easy for us to have discuss with them what are the potential complications. A family that knows about the possibility of, a problem with the Salter-Harris type 5 with a growth arrest, it's going to accept a possible complication down the line much easier. And also, if they're informed about that, they're going to come back for reevaluation even after 6 months or 1 year, just to make sure that everything is going well. Nowadays, I tend to see a lot of plates in adolescents, especially in distal radius fractures. And sometimes we see these little screws coming out of the dorsal cortex. If you're the one who's doing the surgery, do an Hoya view during your surgery just to make sure that you're not going to penetrate the dorsal cortex. Or if you have a patient that's not getting better, even with a benign fracture, the x-ray looks fine. It might be a little bit deceiving because of overlapping of the Lister's tubercles, so just do a CT scan to be on the safe side. Again, another case that the CT scan helped me a lot, clinical examination of a distal radius fracture, but also the patient had tenderness at the snap box, some suspicion of scaphoid fracture. X-ray was negative, but the CT scan verifies that, and that changes your treatment plan and the possible outcome. This is a common injury that we see, fingertip amputation. I'm pretty sure you've seen this a lot. For us, the difference in this case was that the kid came like that, with the amputated part not very well preserved, almost 2 days after the injury. And after discussion, we decided to do a composite graft and hypothenar flap. Although there were, possibility of necrosis, infection complications. That's why I think discussing with the parents and having them informed, involved in your decision making, it helps. The result was, I think, pretty good for the girl. And coming back to my little tricks when I'm dealing with the pediatric trauma, Penthrox, it's something that I always have in my clinic. It's an inhaler that I use whenever I do reductions. If I'm going to remove K-wires, it's a little bit of a sedative, so the kids get a little bit dizzy. They also get funny. They start laughing. Parents are also not as anxious, and things are done much easier. This is another thing that we use, especially if we need to do a small local anesthesia injection. And it's commonly used in the pediatric ward. It's called BASI-B for blood extraction for vaccines, injections. In our practice, we use it because of the vibration and the freezing. It distracts the kids, so it makes it easier also to examine them and to treat them with let's say, a reduction of a fracture or a small manipulation, or even addressing change in very small children. And last but not least, always keep in mind what your teacher might have taught you, or have in mind what one of your teachers might have done in a similar case. Thank you very much.
Thank you. Any questions for Dr. Christina? Okay. I guess the tips are quite useful. May I request Dr. David McComb, if he's here? Dr. David, yeah.
Thank you for the opportunity to present some of our work from the Children's Hospital in Melbourne. This is in reference to what happens with median nerve palsy in the supracondylar humerus fracture group. As we all know, the supracondylar fracture of the humerus, the median ulnar and radial nerves are all very vulnerable, and when you consider the extent of displacement and deformity of the distal humerus and the risk of injury in this sort of scenario, it's not surprising that we see any nerve palsies, but most common is median nerve palsy, and the incidence of that is quoted at 10 to 20%. Although I think if we just think a little bit about how difficult it is to examine these children, particularly in the setting of an acute injury such as a supracondylar fracture of the humerus, they're in a lot of pain, it's swollen, there's a lot of anxiety in the emergency room about potentially about the viability of the limb, and the failure to carefully examine for nerve palsy and particularly to document what you see, I think is really critical when it comes to the ongoing management of it. So when we think about injury, it can rupture. You can rupture the median nerve. It's possible. You can contuse a nerve, have a traction injury, or this sort of injury, an entrapment, either in the fracture itself or in the fascia overlying the fracture, producing this sort of appearance as seen on the right. You can also injure it at the time of reduction, either by excessive traction in a bid to try and reduce the fracture closed, again by inducing entrapment, or if you're cavalier with your K-wires, you can stick a wire through the nerve, as is seen here. The current treatment paradigm for nerve injury in this setting, particularly median nerve, is that for observation, the belief is that it's largely a neuropraxic injury, and most papers that are published would support a non-operative approach and deferring surgery or nerve exploration for those that don't recover at 3 months. We looked at our experience at the Children's Hospital in Melbourne, and the incidence was relatively low, but as I said before, that may be a failure of picking these injuries up. Of that 74 children with median nerve injuries, most of them had closed reductions, as in keeping with the current state of practice. And when you look retrospectively at chart review, on average, mainly because most kids are reviewed at 6 weeks and then 12 weeks, they were said to have recovered in over 90% of cases. However, we had a subgroup that had been referred to the hand therapist for ongoing hand therapy because of their median nerve palsy. And these children, instead of being looked at retrospectively, were being followed prospectively and more carefully than perhaps the orthopaedic resident would have assessed their nerve function. And they're having manual muscle testing, Sims-Weinstein monofilament testing, grip strength. And of that group, that 21 patients who were followed in that way, 12 had closed reductions, 9 had open. And we learnt quite a lot from going back and looking at this particular subgroup. What we learned was the recovery is not as good as it's supposed to be. The recovery in this group was incomplete. we had a number of children who did not recover MRC5, and the time to recovery was delayed. So that would imply that this isn't a neuropraxia. Neuropraxia, nerves intact, should get better by 3 months, but these aren't neuropraxic injuries, in this group at least. And when we looked at the subgroup analysis of the open versus the closed group, we found that even though you would expect that the open group would have been perhaps the worst injuries, they actually recovered faster and better than the closed reduction group. And we looked back at that, and the open reduction group had a greater incidence of vascular compromise at the time of surgery, and not surprisingly, there were more open injuries. So you would expect the open group would be a worse prognosis group, but in fact had better results. And if you look at their ultimate grade of recovery, open exploration had more MRC5 recovery and no poor results, and a faster recovery, quite clearly statistically faster recovery. So, what does this mean? Well, I'm not sure it means we should evaluate every median nerve palsy associated with a supracondylar fracture, but I think it does open your eyes to the fact that this may well be a more severe injury than we perhaps have been led to believe. And I think that probably what we're doing by exploring and performing neurolysis is we're seeing the bad injuries earlier and dealing with them and getting a better result, but also we're addressing that secondary injury that occurs because of ongoing compression of an already damaged nerve due to tethering. So, as I said, the injury is often incomplete recovery and usually slower than it's often reported, and we think it's improved potentially in by open reduction and a neurolysis of the nerve at the time of that. So the take-home messages. What's critical if you're going to sort of make decisions about whether you are or are not going to explore these nerves, these need to be documented properly, and that I think is a message that keeps being said at every conference I go to, and this gets spoken about. But within your own institutions, you'll still find kids where you go back and look at their original case notes, where the documentation of the examination findings prior to surgery is poor. I think that early exploration of the median nerve is a reasonable thing, and we didn't do any harm in our group, and I think we actually achieved benefit for the majority of them. But ideally what we would be doing from here on in is evaluating the high-risk group, and I think high-definition ultrasound is probably the way to go for that. Thank you very much.
Any questions for Dr. David?
So we will continue with my co-chair, Dr. Aniban, who will discuss to us about healing the growth plate, advanced management of physial arrest in distal radius fractures.
Good afternoon, everyone. Moving on to growth arrest in the distal radius fractures. This is not something which is uncommon. This photograph is from Mercer Rang's textbook, and this photograph was described way back in 1898 by Poland. So distal radius fracture arrest is not something new, and it has been there for decades. And it's probably because of a type 5 Salter-Harris injury, which is usually an occult injury. It's often missed on day one, and there is a vertical compression of the physis, and it's only much later that it is discovered. And this occurs in about 4% of cases. So it is a relatively small percentage of individuals who are involved, but when it does happen, it causes a problem. So what are physial injuries commonly managed by? Usually with a cast, and they have a very high remodeling potential because this is the growing end of the bone. But if, as it happens in our part of the country, most of them present to us a little late, after 7 to 10 days, it is always better to leave it alone. Because as Mercer Rang has said, that repeated efforts at that point to try and reduce it will actually cause more grating and more damage to the already damaged goat plate and will almost certainly guarantee a fascial arrest. So what is the remodeling potential and what are the factors that are dependent on that? So one of the common factors which needs to be taken in mind is what is its proximity to the growing physis. If it is really close to the physis and whether that physis is actually the growing end of the physis of that bone, then the chances of potential remodeling are much high. But terms and conditions are to be read carefully. So there is a caveat. The caveat is that rotational deformities do not remodel, as Dr. Dasde mentioned from his normative data. And the other important thing to look at is what is the age of the child, whether the child is a boy or a girl, and what is the time of growth remaining, how much growth is remaining till the skeletal maturity is reached. And these are the three factors which will help in determining whether it will remodel adequately or not. So I have just a couple of illustrative cases. So this was a 10-year-old boy, right hand dominant, fall from 2-story height, non-dominant hand injury, initially treated conservatively. This was the first injury films. And it is only after about 3 weeks, when we took a lateral view, that's when he presented to us. So at this point, if you evaluate the x-rays properly, the diagnosis is that apart from a fascial injury in the distal radius, you also have a injury in the distal ulna, and in the carpus you have a transcaphoid perilunate dislocation, and there is a small bit of a fragment which is probably an osteochondral fragment avulsion. So initially, once we identified it, closed reduction was attempted. As expected, it was unsuccessful, so we proceeded it in an open reduction, pinned the carpals, and since the radial physis was still unstable, we pilled it in situ. And we got a reasonably well aligned position immediately post-op. He was okay, but he returned after 4 years. And at that point, this was his situation. The scaphoid had united, he had a reasonable carpal alignment, but he now had a manus valgus deformity with radial shortening, ulnar overgrowth. So at this stage, the learning from this was that the fascial injury itself is not alone. It can happen with concomitant injuries. So it's important to look for these. And the other thing is that I learned that it manifests late, and so long follow-ups are really necessary. You can't just discharge these children off. So at this point, we have a short radius which is bowed and a deformity which is gradually progressing. So how do we manage with this? The problem is you have a damaged physis, there is a growth imbalance, and apart from that, there is an angular deformity. The possible solutions for the fascial damage are if it is localized or whether the entire physis is damaged. That needs to be assessed. You need to see what is the growth remaining potential for the child, and you need to correct the deformity. The possible strategies are, if the damage to the physis is small, then you can assess that. You can do fascial mapping. So either a CT or a MR, especially 3D MR, you can map what is the percentage of that fascial bar. If it is a small bar, less than 30%, if the child has at least 2 years of growth remaining, then bar excision and interpositional graft, be it fat or methyl methacrylate, does work. It has been shown in certain papers, but is not always replicated. Or you can do a corrective osteotomy, either extra-articular, or you can proceed with any of the joint leveling techniques. That is, either you do a distraction histiogenesis on the radius, which is short, with whichever fixator you are comfortable with, and on the ulnar side, you either do a shortening or a fasciodesis to prevent its further overgrowth. So in this case, so we listed these are the possible treatment options. Either you do a bar resection or a corrective osteotomy, or you can combine all of these. So in this case, what did we do? I did an ulnar shortening osteotomy, combined it with a epiphysiodesis, and also did an open wedge osteotomy of the distal radius and packed some synthetic bone graft in between to try and correct the alignment as best possible. And finally, 1 year after the second surgery, we could get a reasonable alignment, and he's maintained that even throughout. And this is the final collection that could be achieved. Another case, similar child, came to us quite late. After 1 year of the initial injury, he noticed this is what had happened. Similar situation, similar story, diagnosed with fascial arrest. He was referred to a pediatric ortho center in the country where he underwent multiple procedures. So here they first did a orthofix lengthening, corticotomy, and then they did a fascial bar release. And then the fascial bar release did not give satisfactory results, so they went again and did a re-release. So that will answer the question in some of your minds, does it really work? Sometimes it does, sometimes it doesn't. Unfortunately, in his case, it didn't. So he came back in June 2017, now almost 4 years from the original injury, with a recurrence of this deformity. Again, it has recurred. There is shortening in the radius, ulnar overgrowth, and the DRUJ is again unstable. So this is how he presented to me in 2018. So how do we proceed? Again, the entire algorithm is there. These are the options. So what did I do? I first did a external fixator and did a corrective osteotomy in the radius, dome osteotomy, corrected the deformity at the radius, and added an ulnar shortening with a fasciodesis, as I learned. And finally, this was the correction I could achieve, kept the fixator for about 8 weeks, and followed the child up till skeletal maturity. So at 2 years after the final follow-up, we could get a good range and a reasonably aligned hand, though he had a little bit of wrist stiffness and a mild amount of shortening. So the take-home message is that the awareness needs to be there to recognize these injuries. We need to look for the associated injuries. Prevention is always better than cure, and long-term follow-ups can be humbling, and it is needed, especially for these cases. As a surgeon, all the different techniques must be there in our armamentarium, and we may have to combine different procedures to ultimately get a final good result. I welcome you all to Kolkata in March next year for the 7th edition of the annual Indo-US Hand Conference. Hope to see you all there. Thank you.
Thank you very much. Do we have any questions? No? Okay. So I think we can proceed to the next speaker. It's Dr. Harish. He will talk to us about reviving the pink pulses hand, modern management approaches.
Thank you. So pink pulses hand. So this is the most controversial topic in supracondylar fractures. So posterolateral fractures are more prone for these kind of injuries, because you can see here the fracture buttonholes to the brachialis, and the vessels and the nerves sort of get kinked over the sharp edge. So when we see these children, we have to do a comprehensive assessment to get an idea about the severity of the injury, like looking at the swelling, the deformity, ecchymosis, and if there's a brachialis sign. So if these are present, it means it's a significant injury. So in addition to palpation of the pulse and the capillary refilling, we also need to do a neurological assessment and check all the nerves, because it has been reported that whenever there's a median nerve dysfunction, it means both the vessel and nerve are entrapped, and it's an indication for early exploration. So it's difficult to test these nerves with a child with a lot of pain and anxiety. So this simple test, probably we can do an elicit and check all the 3 nerves. So in an absent pulse, the hand can be perfused, what we call as pink pulseless hand, or it can be a poorly perfused hand. So whenever we see that, the simple test, what we can do further to evaluate the injuries is a pulse oximeter or different types of ultrasound images. So pulse oximetry has been reported by this article from Singapore that it is highly reliable and sensitive. So when you use a pulse oximeter, we need to check for a proper waveform. And simple thumb rule is, when we put the pulse oximeter, with the tracing should be very reliable. I mean, it should be easily recordable. We should not struggle too much to get the pulse, the tracing. So this is a good waveform and a poor waveform. So based on this, we can do an objective decision making, where if the pulse oximeter doesn't show any good waveform, it's an indication that we need to explore the brachial artery early. Whereas if it's present, we can observe. Addition to this, a simple device like handheld Doppler in this, we can see the recording of the pulse here. So it gives a fair idea that vascularity is good. Along with the pulse oximeter, it gives an idea that we can sort of observe this child. And it has been validated by Weller et al., where they have observed in 19 of the 54 cases which they observed, did very well. Only one child required exploration because of deterioration of the vascularity. And 4 of the patients of these 54, when they explored, the signal was not palpable on, not recordable on Doppler, they found that all of them had significant vascular injuries. So duplex ultrasound is a very reliable method if it's available. And normally children have triphasic waveform. If there's a monophasic or change in the pattern, that indicates a significant injury and it's an indication for vascular exploration. Angiography is currently not recommended because it delays the treatment. So the controversy in pulse hand is the perfusion school says observe, whereas the pulse school says immediate exploration. This paper by Whitelight all said that any absence of pulse is a significant injury, you need to do early exploration. Whereas there are a lot of reports which say that you can do observation of these being pulseless and after close reduction. Surgical exploration in this paper, Ramesh et al. Have suggested that if there is severe pain, increasing pain and deterioration of neurological function, it's an indication for exploration. So as Shah et al. Have suggested that exploration is indicated only if there is an altered perfusion or an associated peripheral nerve palsy. So AOS could not come up with a proper definitive guidelines on this topic. So another paper says that due to watchful expectancy, there is no need to revisit this protocol. In a recent paper from Bangalore, they have suggested exploration in all cases, especially in the setting of limited resources. They said that it prevents iatrogenic damage and sort of it's a one-time surgery. You don't need to bother much. You can see the vessels and nerves and have a peaceful mind. So if you open something and if you see like this, sometimes you feel that it's better to open. But when it's a cold hand, I always open primarily, though the literature says that you can reduce and then observe. But in a cold hand, I always open, whereas in a pulseless pink hand, I wait and follow the protocols. So what to do now? So I follow these criteria. Clinically look at the swelling, pulse, perfusion, nerve injury. In these investigations, I use the pulse ox as well as Doppler signal. And you type the type of fracture. If it's open fracture, better to explore. Okay, and the time of most often it's a common scenario in our country that children present very late. So in such a situation, we have to consider early exploration. So pink pulseless hand, if there's a monophasic flow or if you associated median of injury, you do immediate exploration. If not, it's a good waveform, Doppler signal is present, do a close reduction, observe and follow up. In follow-up, during follow-up, if the deterioration of the neurological status of the hand turns cold, then you have to do immediate exploration. In case of a median nerve injury, you always have to take caution that is a silent something called as silent compartment syndrome. So one scenario where after close reduction, pulse returns good waveform, you observe. Okay, this is one such case, did well with observation. Second scenario, there is no return of pulse, but waveform is good, Doppler signal is there. You again monitor if there is any deterioration of the signs. In the third scenario, there is deterioration of vascularity after reduction. So in that cases, you need to do an immediate exploration. So this is that paper which say one such paper which says that if there is loss or change in the pulse after reduction or if there is an associated median nerve injury, so you need to do an immediate exploration. So this is one scenario, my own case, where there was a pulse, it was pink pulseless hand. So the good waveform. After reduction, it was a difficult reduction. After reduction, the pulse was not felt, the waveform was poor. So what I did was, I remotely pulled out the K-wires and did an open approach, explored the neurovascular bundle. So fortunately, the vessel was intact, the vessel was in spasm. The pulse came back after we released, after the vessel was released and we put some warm saline and lignocaine. So you can see the pulse waveform return. So fourth scenario, if there is a dense median nerve injury associated with the pulseless pink hand, it's an indication for early exploration. And following that, we need to monitor for at least 48 to 72 hours. Another scenario, especially if the presentation is very late or if there's a median nerve injury, we have to do early exploration. You can see here, the vessels have been exposed. Here in this case, the vessel was found to be thrombosed, thrombectomy was done, the pulse was restored, circulation was restored. This after follow-up, this child actually had some ulnar symptoms probably because of irritation from the nerve or some scarring there. So in summary, SpO2 and Doppler ultrasound images are reliable tools, and very handy tools and readily available. We need to have a low threshold for exploration. Exploration, especially when the pulse ox shows a poor waveform. If there is a monophasic flow or absent flow in the Doppler, if there is an associated median nerve injury, if the presentation is late or if it's an open fracture. And it's always a luxury to have a microvascular surgeon at your disposal. You can have peace of mind. Thank you.
I certainly hope there will be questions for this controversial topic, right?
Why only me? There's no question for you.
Yes,
It's only a comment that
Yes.
every time we have had a pink pulseless hand, when you have opened, almost always, 100% of the time we have found a correctable deformity. It required
The
something,
vascular
it has been either been kinked or held in the
Yes.
tethered to the fracture or the small thrombosis.
Yes.
But then you will find the pulse oximeter will be picking up.
There's one paper by Sabarwal et al. From 97. They say that if you do an early exploration and do a revascularization, there is high chance of reocclusion, restenosis, but clinically it doesn't translate into what do you say?
there are
Significant.
no functional deficits were
Yes,
there.
yes.
Yeah.
But it's always there to do on a side of exploration than to
Yeah,
have.
that's right. I think if
yes.
you have got a good team to do it, I think it's better to explore.
Yes. And other signs is like there's a fracture gap and there is a soft reduction when you're trying to reduce the fracture. The reduction is not proper. It's too difficult reduction. There's anterior fracture gap that indicates there's a entrapment of the neurovascular bundle. So that's one of the subtle signs which we can use that's an indication for early explorations.
I think Sir has summarized it very rightly. You need a proper team. Whenever this topic comes up in a pediatric ortho conference, we find the hands, when we ask for a show of hands, how many would actually explore, very few would say that I would not explore, I'd rather wait. And here in a hand surgery conference, it's the reverse. Everybody is willing to explore. I guess it's probably because of our
Expertise?
Not just expertise, our
Available.
comfort level of actually exploring the vessel ourselves. However, all said and done, not everybody practices in a level 1 trauma center with access to a plastic surgeon or a vascular surgeon. So I think the individual setup of the surgeon also becomes important. If you have access to a vascular surgeon or a plastic surgeon or a hand surgeon who's willing to give you help, then it's better to go ahead and do it at your set. I've had situations where pulselessness was discovered, somebody asked for a Doppler, and 24 hours later when they went with the Doppler report, that's when it was referred to a higher center. So a handheld Doppler is, I think, a very important thing which should be there in the emergency of every hospital, so that can be picked up rather than having to send to a diagnostic center to do a Doppler study. Thank you, Harish, for a wonderful talk.
Thank you.
May I call upon the next speaker, Dr. Vijay Kumar. He'll be talking about a flexor pronator slide, which is an old but a useful tool.
Thank you, sir. I would like to thank the organizers for giving the opportunity to present this flexor pronator slide, old but useful. In 1923, this page described the flexor pronator slide as a surgical option for the late management of compartment syndrome. The flexor pronator slide is an effective treatment option for the ischemic contracture and contracture related to the spastic cerebral palsy. Investigation-wise, we do just X-ray, bone and joint position. This will tell us the status of the joint, whether correctable or needs fusion. The nerve conduction studies will tell us the status of the nerve and the amount of damage. Then we have to assess 5 parameters. Skin, we have to see the status of the skin, status of the skeleton, then sensations, passive range of movement and active range of movements. If when the flexors are acting and when Volkmann angle is more than 50, the muscle slide operation can be preferred. These are the presentation of the patients. These patients can present like this. Then there's this nice paper by flexor pronator slide by Dr. Terence. He has nicely video paper is there, very nicely explained in this paper. So procedure overview, we can see the pre-operative examination, positioning of the patient, and valent injections. Some surgeons like to do in wake-awake local anesthesia, and some do like to do in the tourniquet and with under anesthesia. Then surgical exposure, then deep dissection, we have to identify the ulnar nerve, the median nerve, the radial nerves, and we have to be also cautious about the interosseous vessels. Then the next step is the releasing deeper flexor muscles, checking the release and contracture, release of the flexor pronator origin from the condyle, then final contracture release had to be seen whether it is released or not, then ulnar nerve transposition, then final range of active motion, wound closure, post-operative rehabilitation, and final follow-up. So we do under tourniquet control. There are two types, many types of incision are there. People are preferred by the surgeons. One is like a fasciotomy-like incision, or some surgeons prefer that's a straight incision along the ulnar border. The subcutaneous veins are spared after cutting this skin, spared whenever possible. Only you should ligate when it's unavoidable. The effort is made to protect the cutaneous nerve. If you are able to protect the cutaneous nerve, it is okay. See, here the skin has been cut and the fascia has also been cut. Then the dissection around the ulnar nerve is done to release the arcade of Struthers, the Osborn ligament, and the triceps fascia in order to prevent the ulnar nerve kinking during the anterior transposition. So you see the ulnar nerve has been dissected. The next is to the periosteal elevator is inserted between the brachialis and the common flexor pronator origin from the epicondyle. The elevator is then brought and between the humeral and ulnar head of the flexor carpi ulnaris on the anterior side, and we have to be cautious about the ulnar nerve prevention. And then medial condyle is identified, the pronator, rad, or all the muscles which is released meticulously without joint capsule. We have to be careful that joint capsule should not be open. Then the flexor are detached from the ulna medially and anteriorly, beginning with the origin of the flexor carpi ulnaris. Then after the superficialis, the FDP and FDS are dissected. The extent of detachment depends upon the degree of flexion contracture. It is generally necessary to release the entire proximal portion of the muscle from the central part of the ulna. The dissection of the periosteum is continued to the interosseous membrane and continued along the radial side. At the same time, the detachment is continued on the proximal side of the ulnar tuberosity until the oblique cord is exposed. Sometimes you need to separate from the radius bone, and then you have to see all the fibrous bands are cut. So after that, by bringing together the detached muscle from the proximal and ulnar side at the interosseous space, on the proximal side the contracture should nearly be released. So you have to check it. If the patient is being operated awake, then patient has to do the movements. Otherwise, we have to do the movement and see whether everything has been released or not. The muscles are examined directly. We can examine the muscle whether there's any attachment is there or contracture band is there. Then that has to be removed. So when we in this diagram you can see if we have released from the ulna and from the radius, and the slide and the ulnar nerve and median nerve are intact, the slide we can gain up to 3 to 4 centimeters. Slide we can gain and increase in the length of the this you can see, and the muscles are released and they have been slided down. Then we have to be careful after slide. We have to see whether the ulnar nerve or median nerve are intact, and all the radial nerve, all arteries, they should be intact, so that the slide occurs, and so damage is not done in the latter. So after checking the position, everything is checked, and then closure of the skin and septic tissue and skin is closed. This is a case of congenital spastic hand which being examined and on the table, and after this the excision of the skin and the ulnar nerve is dissected, and then after the ulnar nerve dissected, the the muscles will be separated from the ulna. The muscle can be separated with the use of cautery, or we can use the periosteum elevator also to be on the safer side. And so after that ulnar nerve, we have to see the release of the median nerve also. We have to check whether median nerve is separate. Then interosseous, all the contracture bands are being dissected, and then we can after we have the slided, then we can check the movement post-operative, that whether the complete release is done or not. Then rehabilitation protocols. Immediately after the surgery, the forearm is immobilized with an above elbow plaster of Paris with the elbow at 90 degree, forearm in the supinated, wrist in extension and fingers in full extension for 4 weeks. Then removal splint is continued for 4 weeks, allowing removal for the therapy and range of motion exercises. After 2 months, the splints are changed to nighttime splints and continued for 4 weeks. The splints are discontinued 3 months after surgery. The risk and complications associated may be overcorrection, the deformity, decreased grip strength, undercorrection, contractures, ulnar nerve, neurobrachial nerve may be damaged, or delayed wound healing. So the treatment for non-ischemic contracture of the wrist and finger requires pronator slide surgery to simultaneously correct the deformity without losing the resting muscle length and strength. So though all this, the technique is old, but it is useful. Thank you very much for your patient hearing.
Any questions for Dr. Vijay Kumar? Yeah, thank you, Dr. Vijay Kumar. We'll move on to the final speaker, Dr. Rajendra, to talk about free functioning muscle transfers in VIC.
Good evening, everybody. As we know that open systemic contracture refers to a spectrum of clinical presentations which are due to missed or inadequate treated acute compartment syndrome. And all the tissues from skin to bone can be involved in this depending on the severity. And the main pathology is due to ischemia of forearm. There's a fibrous replacement of a muscle, and all this fibrous tissue causes a contraction leading to the contractures of a wrist, forearm. Additionally, there is also the nerves are entrapped in these scars, causing a sensory and motor paralysis. This is how the clinical presentation, multiple debridements, then subsequently grafting or flap cover, then they present with the VIC later. So Suke classification classifies VIC into the 3 depending on the number of muscles involved, mild, moderate, severe. In a severe, all the flexor muscles and a part of extensor muscles are also involved. And my topic is on this topic, severe contractures. They present like a complete loss of forearm muscles, scars, contractures, web space contractures, so the main treatment of this VIC in severe contracture is we have to replace a muscle, like a free functioning muscle transfer, need a protective sensations, neurolysis or nerve grafting, and we have to release contractures or sometimes arthrodesis at a wrist and a thumb. The main treatment protocol is, if a skin condition is good, neurolysis, excision, and which helps in good sensation, then as a second stage, do the free functioning muscle transfer. If a skin condition is not good, usually we do the abdominal flap and followed by the neurolysis and free functioning muscle transfer. So first stage, excision of a necrosed of flexor muscles, contracture release, neurolysis, nerve graft, and any abdominal flap if a skin shortage, followed by the free functioning muscle transfer. So as we know, free functioning muscle transfer involves the transfer of a muscle from distant location to replace the lost function. This procedure involves the microvascular anastomosis and neural coaptation. Among the various muscles, gracilis is commonly used because of its various characters, its size, excursion power, independent neuromuscular component and a single motor nerve of a sufficient length. And the principles for free functioning muscle transfers holds good, like tendon transfer. There should be a passive joint movement. Muscle should be expandable, sufficient amplitude muscle power of the muscles which are transferring. Operative procedure we do if they come with the compartment syndrome, or if there is a skin scarring, everything, complete debridement followed by the abdominal flap. Then do the neurolysis, and if there is any nerve is deficient, do the nerve grafting, contracture release, and nerve both ulnar and median nerve both are neurolysis or nerve grafting depending on the requirement, and sometimes contracture release, first web contracture release and a flap cover. Then as a second stage we do a free functioning muscle transfer where preparation of the medial epicondyle, then neuromuscular bundle is identified, then distal FDP tendons are prepared for the transfer. Then gracilis is harvested from the thigh with complete length with a good tendon and neuro and nerve and artery as a then we do the first fix it to the medial epicondyle, then vascular anastomosis, nerve coaptation, then finally distal tendon repair. So post-operatively patient is immobilized for a period of 4 to 6 months, then gradual rehabilitation and muscle stimulation for the next 3 to 6 months, then slow activities of the hand. So these are some of the cases. This patient with a Volkmann's ischemic contracture, initial abdominal flap was done along with the neurolysis, and we did a second stage free functioning muscle transfer where median branch of a median nerve is used for a nerve coaptation and end to side brachial vessels to brachial artery and vein, nearby vein. So this is a result after 2 years. Basically we cannot regain all the functions. They should be able to have a good grip strength so that their day-to-day activities, this after a year, she is able to do all her activities. She is able to hold and she is completely independent now. And that too is the left hand, so her main hand is the right hand, so it's more supportive. She holds. So this is a second case. This patient they presented with the compartment syndrome, debrided, abdominal flap was done. In a second stage, because of we wanted to reduce the surgery number of surgeries, we did a neurolysis and a free functioning muscle transfer and same anastomosis to the end to side to brachial artery and nerve coaptation to the median nerve, one of the branch. So this is how he is. So he is also completely independent of the function now. This is another patient, 17 year, complete Volkmann's contracture of the forearm. Contracture was there with the physiotherapy, able to good passive range of movement. Then we did a free functioning muscle transfer now, and also flap for the web space. And now he is able to do his work independently. So this is our statistics over a period of 5 years, 8 patients, and assessment is done by the MRC grading for the finger flexion and sensory loss and dash score for the assessor function. And these are patient details and duration and the procedures. In some of the few cases we have done some secondary procedures like orthodesis of a thumb, CMC. And the main in motor recovery, all the patients were able to grasp objects, use their hand for day-to-day activities, and they have a variable sensory recovery. And so in conclusion, free functioning muscle transfer with a gracilis is a reliable option for restoration of a finger flexion in a VIC patients with the severe involvement of a muscle of a forearm. Outcome is better when done after an early preliminary stage of excision of a fibrosed muscles and neurolysis, which allows the recovery of intrinsic muscle function. And FFMT is the best carried out 3 to 6 months after first stage with a supple skin and good passive range of movements of a finger. Thank you.
Thank you. The paper is open for any questions. Yes, there's a question from the floor.
That's a very good result. I have a couple of questions. And I asked to everybody who does Bachmann ischemic contracture. Presumably, like a hypothetical situation, the patient comes to you, mostly children, after 36 hours, well-established Bachmann's. Would you like to wait and watch till the contracture develops and then treat it with the free functioning muscle transfer? Or you would like to release the compartment, number one. Number two, if you do the follow-up of the children whom you have done the free functioning muscle transfer of the gracilis mostly, do they cope with the growth of the radius or the forearm, or the muscle becomes shortened, or they keep growing with as the child grows? In a follow-up, like when they become adult.
Okay. For the first question, yes, sir. We if they come, we do the release, and if the skin condition is not good, we do the flap cover, release of a nerve, and wait for 3 to 6 months. Depending on that, then we go ahead with the free functioning muscle transfer. And for a second question, I didn't understand.
In the pediatric cases that you had, after doing the free functioning muscle transfer, as the child grows, did you find that the muscle tended to develop a contracture, or did the muscle also grew along with the bone? I hope that is the question you are asking, sir. Yeah.
So we followed these children for a period of 3 to 4 years, but I didn't find any. Find any contractures in that.
Hello,
One
sir.
more question.
Yes, sir. My question is that in most of the cases you've done neurolysis or nerve reconstruction, followed by that when you're doing an FFMT. So at what level do you take the nerve, like when you have to coab the nerve to the donor nerve?
Generally, there is multiple branches of a median nerve comes to flexors. So all the flexors are gone. So we just trace whatever nerve is available.
In the forearm?
Forearm, yeah. Just at the upper arm, or just at the wrist, I mean elbow level or just below the level.
I think, thank you, Doctor. With that, we'll close this session. And thank you all for patient hearing here. And thanks to all the speakers to keeping to time. Thank you.